All right. We are exactly at 2 o'clock, so we always have a lot to cover, so I'm just going to go ahead and get started. Good afternoon, everyone. Welcome to our February maternal webinar. We're going to be focusing on congenital cardiac lesions, which is our 5th lecture in our cardiac education series. We do plan to have a Q&A if we have time at the end of the webinar, but please add your questions in to the chat at any time. We are recording the presentation, and everything will be available on our website at www.georgiapqc.org, as well as on our Microsoft Teams channel for those that have access. And also, if everyone would please mute their lines to avoid any distractions, that would be wonderful. So just a few updates. Our next maternal webinar is scheduled on March 7th. The topic will be valvular heart disease, and our speaker is Marissa Plattner. And I know many on here have some questions about the quarter 3 and quarter 4 hypertension data submission for GAP-QC via Survey 123. As many know, we are transitioning to Survey 123. We've received some feedback from our initial submissions in December, and we've been working to improve the survey and also the instructions that you all receive. We want to make sure we get some improved instructions out, some simplified directions, as well as some updates on the back end that I think y'all would be happy to see. So there will be an extension for quarter 3 and quarter 4 hypertension data. We're going to extend that to March 1st, but again, appreciate everybody's already gotten that in. You do not need to resubmit if you've already had it in. We just want to make sure we're improving internally, as we are an improvement organization. So again, just grateful for everybody's patience and understanding as we roll this out for our next generation GAP-QC. So I think some of you on here understand the phrase pain with a purpose. So again, appreciate the patience. Just a reminder, our annual meeting will be on April 13th and 14th. The first day will be in person at the Emory Conference Center, and the second day is virtual. And we're gonna, I believe we'll have the event information, including registration, that's gonna be sent out over the next few weeks. So please keep an eye out for that. And then lastly, the Institute for Perinatal Quality Improvement, IPQI, I sent an email out a couple of days ago, I believe, created a 28-day anti-racism challenge. It's their version 2. I think they've provided this before, but this is really a great opportunity to support your respectful and equitable care efforts as part of the patient safety bundles. The challenge is really designed to enhance your insights and provide tools to support all your anti-racism efforts. Each day there's a quote meant for reflection, a learning activity, and a recommended action. So it's reflect, learn, and act. So really, really kind of engaging challenge. It's a great opportunity for a group of colleagues to join. And even though we're on February 7th, you can join now and still participate. So it's not too late to do so. And the link is listed here. Just for those that aren't familiar with GAP-QC, our website, we're updating our website, but here's where all the lectures are going to be listed. So you'll be able to click on the playlist here, and here are the recordings, as well as download the presentations. And then hot off the press, this is what we're working on. Our cardiac conditions and OB care initiative, we are still enrolling. So if there are folks that are interested, this map is a little hard to see, but you see the red. Those are our facilities that have enrolled in our cardiac initiative so far. The yellow is our hypertension facilities. And of course, we're spread out across the state, but there's definitely much opportunity in those areas where we are not. For those to join us. So you'll see the birthing hospitals are listed as H, and they're in a blue kind of square here. We'd love more participation, and we're always open to engage folks into our patient safety bundle initiative. So please, if you're not on here, please reach out to me, and we'll get you all set up. And here's our key driver diagram for our cardiac conditions initiative. Okay, so our goal is to reduce severe morbidity and mortality related to maternal cardiac conditions in Georgia. We have a SMART aim set by February 6, 2026, National Wear Red Day, to reduce harm related to existing and pregnancy-related cardiac conditions through the 4th trimester by 20%. You'll see the 5 R's as the key drivers that you all are familiar with, and then the interventions listed on the right. We have our what is highlighted is our structure measures. So these are key structure measures for this bundle. And the first structure measure is establish a multidisciplinary pregnancy heart team. The second one is in all care environments, assess and document if a patient presenting is pregnant or has been pregnant within the past year. The third structure measure is provide patient education focused on general life-threatening postpartum complications and early warning signs, including instructions of who to notify if they have concerns and time and date of a scheduled postpartum visit. Fourth is to perform multidisciplinary reviews of serious complications to identify system issues. And last structure measure is to include each pregnant or postpartum person in their identified support network as respected members of and contributors to the multidisciplinary care team. And then this is our the key driver, reporting and systems learning key driver for this for the cardiac initiative. Here are six process measures. And process measure 1 is a standardized pregnancy risk assessment for people with cardiac conditions. Process measure 2 is a multidisciplinary care plan for pregnant people with cardiac conditions. P3 focuses on OB provider nursing education on cardiac conditions. P4 is education on respectful and equitable care. P5 is emergency department provider nursing education on cardiac conditions. And lastly, it's our optional process measure is the CVD assessment among pregnant and postpartum women. This is among women who do not have a diagnosed cardiac condition. So I just want to stress the two here for our presentation today, which is really the focus on people with cardiac conditions and what we need to do as our process measures in this patient safety bundle with this key intervention. So with that, Dr. Duty, I'm going to hand it over to you to introduce our speaker today.
All right. Thank you so much, Lisa. It is my great pleasure to introduce Clayton or Tony Smith, who is a cardiologist and assistant professor of medicine and pediatrics at Emory University. Dr. Smith has the great honor of having the most board certifications of anyone I've ever come across. He is board certified in internal medicine, pediatrics, pediatric cardiology, and adult congenital heart disease. Dr. Smith is originally from Kentucky and graduated from Indiana University School of Medicine in Indianapolis, after which he returned home to the University of Kentucky Chandler School of Medicine and Kentucky Children's Hospital for a combined residency in internal medicine and pediatrics. He then moved to Atlanta, where he trained as a pediatric cardiologist at Emory University and Children's Healthcare of Atlanta, followed by a fellowship in adult congenital cardiology and advanced cardiac imaging at Emory. He's been on faculty with the Emory Adult Congenital Heart Center since 2020. His academic interests include the successful transition from pediatric to adult care, which is so key in this population, long-term outcomes of congenital heart disease, and the use of MRI and CT in the evaluation of congenital heart disease, as well as 3D modeling and printing. He also has an interest in the management of pregnant congenital cardiac patients. He's had the opportunity to speak on this topic both locally and at the American College of Cardiology. In his free time, he enjoys spending time with his wife, 2 daughters, Emily and Abby, as well as his 2 golden doodles, Ulysses and the very aptly named Echo. So thank you so much, Dr. Smith, for joining us today.
Thank you for that really nice introduction. So thank you all for letting me come and join you today. I think my number of board certifications were just that they kept trying to make me remediate. They just said I wasn't ready to practice on my own. So I just kept training and training and training. Let me see if I can get this switch back over. Hopefully you all are seeing the slides. So we're going to talk about kind of a complicated problem, but anything that has to do with congenital heart disease is pretty complicated. But we're going to really review kind of an approach to managing pregnancy and congenital heart disease. I don't have any disclosures other than the fact that I think that when I did my OB/GYN rotations during medical school, they tried to fail me out. So you all know a lot more about OB than I ever will. So I am most definitely just a cardiologist. I call myself a very fancy plumber. Our objectives for today, so we'll review some of the physiologic changes that happen during normal pregnancy and how they impact cardiovascular function. This is probably a review for most of you. We'll understand the essential role of preconception counseling in women with congenital heart disease. We'll be familiar with some of the, and then we'll review some of the pregnancy issues related to selected congenital heart defects. So that'll be the kind of bulk of today's talk. Specifically, I chose these 4 kind of left heart obstructive lesions, tetralogy of Fallot or other countertrenchal problems, pulmonary hypertension or Eisenmenger syndrome, and then single ventricle palliated patients or those with a Fontan. We'll not cover connective tissue disorders or isolated valvular disease because I think those are going to be touched on in other talks. So just to start, I think any good talk needs to have a case. So This is a young woman. She's 21. She's a G1P0 who had a history of tetralogy of Fallot, underwent initial repair early on in life, and then had a later residual VSD and enlargement, or VSD closure and enlargement of her right ventricular outflow tract and LPA at 10 months, and ultimately had surgical pulmonary valve replacement at 15 years due to progressive RV enlargement. She presented at 10 weeks gestation to her pediatric cardiologist office, a bit of a surprise, and you can imagine the pediatrician was a little shocked by this. This was just her baseline echo, showing that she had kind of low normal LV and RV function. And then when we looked at her pulmonary valve, her artificial bioprosthetic valve showed that she did have some stenosis through the valve, kind of in the mild range, as well as a fair amount of regurgitation, probably in the moderate range. So what's the scope of the issue? This is largely me preaching to the choir here, but as we know, the maternal mortality rate in the United States has increased per 1,000, especially when we compare ourselves to other developed countries. This is particularly a problem here in Georgia. I think obviously we all know this, and we know that this disproportionately impacts those of minorities more than folks that are Caucasian. Of all of the issues or problems that account for maternal mortality in the U.S., cardiovascular disease is number one when you combine the different causes of CV disease. And I think that our growing congenital population definitely plays into part of that. So as we know, the physiological changes in pregnancy, they really do look like heart failure. And that makes it very challenging to determine in our patient population, because so many of our congenital heart patients, their big problem that they run into is heart failure. I call it heart failure with unusual plumbing. And this is a high flow, low resistance circulation. So fortunately, we have multiple statements to kind of help guide our management of these patients, such as this one from the AHA back in 2020, looking at the different hemodynamic changes of pregnancy. And as we know, cardiac output increases up to 30 to 50% above baseline. We have increased preload, decreased afterload as the systemic vascular resistance and pulmonary vascular resistance reduce, and an increase in the heart rate. And the overall resistance decreases to accommodate that increased flow. I love this diagram. I think it really kind of hammers home those changes and how, and we'll kind of touch on how that impacts the congenital heart population a little bit later in the talk today. Looking at particular areas of increased risk kind of into that second trimester, heading into the third, as well as at delivery in the immediate postpartum period. So another nice graphic representation of kind of those changes that we see throughout pregnancy. Again, significant increase in cardiac output with a dropping of the blood pressure early on, with later increase, and a need for augmented cardiac output with elevated heart rate, as well as a decrease of your overall systemic vascular resistance. And one last thing to kind of hammer that home, and kind of the L&D phase and then the postpartum phase. So I think any discussion on management of congenital heart disease patients that are pregnant has to start with an understanding of the preconception. And again, I think I'm preaching to the choir here. I've given similar talks to my cardiology colleagues, and I really hit this hard because I think that this is something we don't do very well as cardiologists. And I refer a lot to this guidance statement, the scientific statement from the AHA, done by a lot of our national colleagues in congenital heart disease from just a few years ago, from 2017. And in that guideline, kind of the approach to management of the congenital heart patient who's pregnant, one of the very first things that really comes up at the very top is this whole idea of preconception and maternal fetal risk assessment. And I emphasize that extremely much with all of my colleagues and anyone that I kind of give this talk to, because I think if we don't do this well, the rest of what we're going to do is not going to be done well. And we really set ourselves up for failure in this patient population. Just to emphasize it even more. As we know, the teenage birth rate has been high throughout much of the United States. I think when you look at Georgia, especially southern Georgia, we see a lot of red. So there's a very high teenage birth rate in our state. And our congenital patients are part of that. I think one of the most dangerous portions or time periods for these young people's lives is that transition period from about 18 to around 24, 25, where a lot of them are lost to care. A lot of them may be only seeking care with a primary care physician, and a lot of them may present pregnant. So one of the most common ways that we get patients that have fallen out of pediatric care coming back into our team is when they show up pregnant at Midtown or with one of the outlying OBGYNs. So just something to be very keenly aware of. So we know that pre-existing chronic conditions contribute to more than half of maternal cardiac deaths. And more than 90% of female children with a heart defect are now reaching childbearing age. And that number is getting bigger and bigger as the years go on. It means that the pediatric cardiologists and the pediatric cardiothoracic surgeons are doing their job really, really well. And many of those patients will choose or accidentally become pregnant with significant risk to themselves or the baby. So, and a lot of times they don't understand that risk. They've never been talked to about it. They may have been talked to once or twice when they were much younger. A lot of the pediatric cardiologists don't necessarily do this kind of counseling. So I think that it really does fall on kind of those that are involved with the transition process to really hammer this point home, which I think involves a discussion and prescription of appropriate and effective contraception. So this is something I've talked to my pediatric colleagues a lot about. They're not always very comfortable with this discussion, but I think both, not just OBGYNs, but also cardiologists should be having this discussion. So. As we know, we have a number of risk assessment systems to kind of help determine risk in patients with prior cardiac disease. I'm not going to spend a lot of time on this because I have a feeling most are pretty familiar with this, but the Sahara is shown here. We have the CARPREG risk stratification here. And then my personal favorite remains the modified WHO system, which was originally published in 2006 and integrates all known, sorry, somebody's calling me. So sorry about that. Integrates all known maternal cardiovascular risk factors, and there's a significant emphasis on specific type of congenital heart defects. So it's very useful for us when we're counseling our patients. And it analyzed both maternal and offspring risk with mortality and morbidity looked at. So just looking at our different modified WHO classifications, as we know, it goes from 1 to 4 with this kind of unusual category of the 2 to 3, kind of right in the middle, with increasing risk of mortality and morbidity as we progress in the risk category. Just briefly, we'll touch on each of the categories. So risk category 1 is really reserved for patients with simple congenital heart defects that have either been repaired or are thought to not be hemodynamically significant, such as a small PDA. Category 2, it accompanies a lot of our kind of low to moderate complexity lesions, that things like ASD or VSD that was isolated that has not been previously operated on, or something like repaired tetralogy of Fallot, although we'll touch on that a little bit more later. And then arrhythmia falls into that category. The 2 to 3 I find to be one of the biggest catch-alls. So pretty much anyone with native tissue valve disease that doesn't fall into one of the other categories falls into here. Marfan syndrome without aortic dilatation. Those with repaired coarctation of the aorta, which we'll touch on more. Risk category 3 has the mechanical valves. This is where the single ventricle patients fall into. those with cyanotic heart disease, other complex forms of CHD. And then finally, category 4, these are anybody with pulmonary arterial hypertension, bad dysfunction, significant left heart obstructive lesions, such as aortic stenosis, mitral stenosis, or coarctation, aortopathy syndromes with significant aortic dilatation, and then Fontane's with complications are also included into this. As we know, fetal risk is high in this patient population. The highest risk is preterm birth, which can happen in up to 65% of all congenital heart pregnancies. There's an increased risk of pregnancy loss, which we'll look at a little more in detail. IUGR, small for gestational age, intraventricular hemorrhages. There is an increased risk of fetal CHD depending on which lesion the mom has. And then perinatal mortality can also be quite high. So just looking at kind of association of different risk in different forms of congenital heart disease, we see a significant increase in patients with complex disease, such as single ventricles, those who are cyanotic. Usually the more simple forms are generally better tolerated with a higher rate of completed pregnancy. This is, again, looking at some of the fetal outcomes with different types of congenital heart disease. So again, Fontane's, cyanotic heart disease patients, those are all at significantly higher risk. So what's my approach? So I look at the patient's functional status by history and exam. This is all assuming I'm meeting them before they become pregnant. Unfortunately, that frequently does not happen, as our MFM team will here at Emory will tell you. They hear from me not infrequently that I'm meeting somebody for the first time in a fairly advanced stage of pregnancy. We evaluate their risk category with a combination of the available stratifiers. I frequently will do cardiopulmonary exercise testing on anyone who's kind of in the intermediate stage. There's been some nice studies that have shown that better performance on CPET with higher peak VO2 and higher maximal heart rates suggests that you will be able to tolerate a pregnancy better. I have a in-detail risk discussion with the patient. Frequently, I'll refer to our MFM team for obstetric counseling as well. There may be a role for genetics referral in certain types of diseases, but ultimately it is the patient's decision. All we can do is give our recommendations and support them. So, and I always tell them, or the worst pregnancy in CHD is the oopsie pregnancy. And I think I supposedly said that at some point. So we'll move into the bulk of today's talk, and that's going to be really focused on looking at pregnancy issues, pregnancy management, and some selected forms of congenital heart disease. I'm going to start with left heart obstructive lesions. This does have some overlap with the valvular disease talk, but I do think that given that left heart obstruction tends to be something that we deal with a lot in the congenital heart world, I thought that it'd be worthwhile to kind of cover it today. The most common of those that we see are patients with bicuspid aortic valve. This accounts for 1% to 2% of the total population, so it is the most common form of congenital heart disease out there. It's the most common cause of isolated aortic valve stenosis in adults and can present with significant valve disease fairly early in life. So we can see thickening of the valve even as early as the second decade. We do occasionally have children who will present with bicuspid valves with significant AS that have to have intervention in the first decade, although that's more common in people who have kind of a unicuspid valve where really there's only one functioning cusp to the valve. And this is a nice path specimen showing those two leaflets instead of 3. The lesion progresses to significant aortic stenosis in 75% of patients requiring eventual surgery at some point in life. I tell people it's 80% by the time that they're 80, because I think that's a very easy way to remember that. They can have progression of aortic valve regurgitation or associated aortic dilatation. We'll also talk about coarctation of the aorta. So coarctation of the aorta is a congenital condition whereby the aorta narrows in the area where the ductus arteriosus inserts. It causes a blood flow to the aorta, kind of in that distal area. I'm going to just grab my laser pointer here. We can see kind of in this area of narrowing. So blood flow to the aorta is distal to that narrowing is dependent on the ductus arteriosus, or the PDA, early on in life. Usually that goes away. And if it goes away early, the child may become very ischemic related to that. You can also get, as the PDA closes, that will actually cause the coarctation to be more present. And then postductal narrowing is fairly rare, but, or excuse me, postductal narrowing. So normally the narrowing is happening right at the ductus site. You don't usually see narrowing more proximally to this or more distally down into the descending aorta. I think we had an interesting case recently here with a much more distal coarctation in a patient that we thought was more related to an inflammatory condition rather than a congenital diagnosis. Coarctation has widely been considered a simple congenital heart defect. I think that it's probably not as simple as we think. It has a lot of late complications associated with it, including early systemic hypertension, premature atherosclerosis, CV events. They frequently can be associated with bicuspid valves, and you can have recurrence or residual coarctation. So this is a nice 3D reconstruction of a patient I've taken care of. And you see this patient had a prior coarctation repair. You can see that there's still an area of narrowing there. As they aged, they actually developed a recurrent obstruction. So even if they had good surgery when they were a child, things can definitely change over time. This is another kind of cross-sectional image of a patient with a recurrent coarctation. So again, we can see that area that's pretty tight. This patient had had a prior patch type repair, which is why you see such a big dilatation of the proximal descending aorta here. And then this patient underwent coarctation stenting. So one of our interventionalists went in and put a nice stent to open up that area of narrowing. So that tends to be our main approach. So looking at left heart obstruction in pregnancy, so the degree of risk related to these diagnoses really depends on the degree of obstruction. But most of them are considered fairly high risk. We can see even the ones that are considered kind of lower, quote unquote, lower risk are still falling into the 2 to 3 category. Even a repaired coarctation who's otherwise doing well is still 2 to 3. From a standpoint of aortic stenosis or bicuspid aortic valve, those with mild to moderate stenosis usually do okay. We usually don't worry about them too much. And interestingly, there's been some recent papers that have suggested that most that have moderate to severe stenosis actually can do well. This was one study that looked at 60 patients who had moderate to severe aortic stenosis. 8% of them developed heart failure during pregnancy, and they had a 10% low birth weight of the fetus. So there is a significant risk, but it's not like everybody who has severe AS is going to develop major problems. 49 pregnancy, another study looked at 49 pregnancies, half of which had severe stenosis in the mother. There were no cases of mortality. And the overall complication rate was 10%, which was predominantly heart failure with pulmonary edema, atrial arrhythmias, and then one patient actually underwent intervention, had stenting, had a TAVR valve done during the pregnancy. However, despite this data, anybody who has severe aortic valve stenosis, we still recommend that pregnancy is avoided just due to the risks of arrhythmia, myocardial ischemia, and worsening LVH and possibility of either diastolic or systolic dysfunction. So we try to keep people who have severe aortic stenosis away from pregnancy if we can. That doesn't always happen. I think we should also point out that aortic dilatation in the setting of bicuspid valve, anybody with a aorta greater than 45 is also considered class 3. We generally will recommend that they have their aorta intervened on prior to a pregnancy if they're measuring in that range. What about the idea of doing valve or aortic interventions during pregnancy? So ideally, I think this is an obvious point, but interventions should really not occur during the pregnancy and should occur prior, hence our importance of our preconceptual counseling. We generally will reserve interventions for those that have severe stenosis, kind of with a peak velocity on echo greater than 4.0 meters per second, or a mean gradient of greater than 40 millimeters of mercury. However, there is some growing literature on doing interventions in those patients that present with severe stenosis that are pregnant. So, and we kind of dove into that a little bit. So this is a rather recent paper in 2022 looking at different transcatheter interventions for pregnancy. Surgery is obviously not a great idea in these patients. It's basically impossible to get them through a surgery if they're early on in the pregnancy without experiencing fetal loss. But transcatheter interventions are a very promising way of us kind of dealing with these issues if they should arise. So they looked at two things. One was balloon valvuloplasty of the aortic valve. So this is just going for isolated aortic stenosis and relieving that stenosis and usually leaving the patient with a significant degree of regurgitation. Overall outcomes were quite good. There were few fetal adverse outcomes in this. You did have one that needed an emergency C-section at 32 weeks, but the initial intervention was at 19 weeks, so they were able to buy quite a bit of time. So really we see that even though the interventions were happening fairly early, most of the patients did quite well and were able to get pretty far along in pregnancy. There have also been multiple case reports of TAVR, so transcatheter aortic valve replacement during pregnancy. Again, this has largely been done in patients at an earlier stage. I would say if you have somebody who's approaching pretty solid viability, just getting the baby out is probably your best strategy. But again, overall experience has been quite good. Most have made it to full term. I think there was one that only made it to about 33 weeks. Overall maternal complications have been low, with one that had a left bundle branch block and one with premature rupture of membranes that resolved on its own from what the authors wrote, and then there were no fetal complications. So overall, pretty good outcomes, but obviously still not something that's done a whole lot yet. And then I always ask as a pediatrician, what's the long-term impact of these radiation doses on the fetus and the child? These are very high doses that they're getting during these procedures. What kind of impact might that have on down the road? So ideally, avoiding that makes sense, but sometimes we just don't have an option. Likewise, looking at coarctation stenting, this was another study kind of from a different group looking at various patients. I think they had 10 different patients that they stented, and some of these were done during pregnancy, again, fairly early on, usually in the late teens to early 20s of gestational age. A lot of them are very hypertensive going in. Again, they had overall good outcomes from this. All 4 of the patients that were pregnant when they did coarctation stenting had healthy full-term babies. One did have a spontaneous rupture of the fetal membrane that physiologically resolved, and another had a femoral artery thrombosis just from the catheterization itself, but was treated surgically without any long-term issues. So we'll turn our attention now to tetralogy of Fallot, and I lumped that with conotruncal lesions. So I have to always put a little bit of anatomy in here. So tetralogy of Fallot, as a reminder, is a series of 4 issues that come in the same patient. They have a large VSD caused by anterior malalignment of the conal septum, which is this kind of ridge of tissue between the aorta and the pulmonary valve. That's thought to create all the other issues related to tetralogy. It causes the aorta to get pulled over the crest of the interventricular septum, something called override. It creates RV outflow tract obstruction here, and then you get secondary RV hypertrophy related to that obstruction. Patients for their surgery, which is generally occurs in the modern era within the first 3 to 6 months of life. Patients will undergo a closure of their VSD with a patch, and then frequently will have a patch placed through the RVOT to relieve that obstruction. Sometimes if the pulmonary valve itself is too small, the surgeon will actually cut across the valve and destroy it, so leaving the patient without a functional pulmonary valve. But that's something that we've dealt with for a long time and can be tolerated for years. Unfortunately, the repair of tetralogy does have chronic issues, so they can get a chronic pulmonary valve leak leading to RV enlargement. They can have residual RV outflow tract obstruction, progressive dysfunction of the right ventricle, arrhythmias, including both atrial and ventricular arrhythmia, and an increased risk for sudden death. And these are seen, tetralogy is, I think, a very nice representative lesion for other forms of right heart disease, specifically things like double outlet right ventricle or truncus arteriosus. These are similar lesions that have kind of similar problems that we deal with in the long term. Not as important to think about what happened to them when they were a baby, when kind of as an adult they have similar problems. So this is a nice cardiac MRI image of somebody who had a prior TET repair, and we see a fair amount of aortic regurgitation, which is that little white jet that you see going backwards there. Risk in tetralogy of Fallot largely depends on the degree of valve dysfunction as well as kind of how the right heart is doing. There is some question whether those with a functioning native pulmonary valve, such as a valve-sparing repair, or those with a bioprosthetic valve are likely at less risk for pregnancy complications. I think it simply makes sense that they probably are in better shape. The heart is happier, the right ventricle is happier once they have a functioning valve. So I think that they tend to do better, but we'll look at that a little bit more in detail here in a minute. As we see repaired tetralogy of Fallot, I consider this repaired TET with a well-functioning valve and a good RV is considered risk category 2. Those with a significant pulmonary valve regurgitation should probably be in that 2 to 3 category. And then those with stenotic lesions are usually considered to be at higher risk than those with regurgitant lesions. So this was a study from 2011 looking at, and this was really kind of driven out of the Zahara data, from what I understand. They looked at 157 pregnancies and 74 women that had tetralogy of Fallot. In that group, there was 30 miscarriages, which accounted for 19%, and then 4 elective abortions within that population. Which is, this miscarriage rate is somewhat higher than the general population miscarriage rate. So these patients are at definitely increased risk. They looked at kind of a combination of different features of the patients, those that had prior completed pregnancies and those without. Really didn't find a significant difference in a lot of these characteristics that we talk about with patients who had prior TET repairs. And then here are your just basic data. Looking at kind of the demographics of that population. And I think things that were noted is that, see here, there were a few things that seemed to have pretty high risk for obstetric and cardiovascular events and offspring events. So, patients who had a history of prior arrhythmia was one of the strongest indicators, which kind of makes sense with what we see with Zahara and Carpreg. Those who had a prior pulmonary valve replacement, interestingly, had kind of higher risk across the board. That probably indicates that their right heart was a little sicker heading into a pregnancy, that sick enough that they needed a PVR at some point. RV outflow tract obstruction had kind of a slight increase in their odds ratios. Those with significant pulmonary valve regurgitation didn't seem to have that much more risk other than just for offspring events. And then when you look at this with a multivariable analysis, the things that really jump out are use of cardiac medication. This is largely antiarrhythmics or diuretics, suggesting that the heart itself was not in great shape heading in. And those with prior palliative surgery, such as a Blalock-Taussig Thomas shunt or something similar, and those with again, the medication for offspring events all kind of showed you that those were kind of high risk issues. And again, kind of pointing out the arrhythmia side of it as well. Pulmonary valve interventions during pregnancy haven't been described a whole lot in the literature. This is going back to that same paper we looked at earlier. Basically, we see that there are a few cases of patients undergoing balloon valvuloplasty, and then a few patients who had pulmonary valve implantation done in the cath lab. Overall, it seems that outcomes were reasonably good, although in one of the PVR patients, the mother did suffer preeclampsia. I do think it's interesting both of these mothers had prior conduit type repairs where we put in an artificial conduit early on in life. Those tend to be thought of as a higher risk just because they're more rigid than a native RV outflow tract. So a little bit different of a population there. So tetralogy of Fallot, pregnancies increase risk, but is dependent on patients. The best results probably come from more aggressive optimization by us, the cardiologists, before a pregnancy. C-section is rarely indicated in these patients, especially unless they have significant aortic dilatation, arrhythmias, or CHF. And then like any other patient, they're going to need regular cardiac and MFM monitoring. We'll turn our attention now to pulmonary hypertension and Eisenmenger syndrome. So as a review, Eisenmenger syndrome is a very specific form of pulmonary hypertension that is caused by the presence of a long-standing shunt in the heart, usually from a VSD, but also can be due to an ASD or pulmonary partial anomalous veins or a PDA. That increased shunt over time leads to extra blood flow hitting the pulmonary vascular bed. Over time, that damage caused by that increased flow causes a number of different effects to the PAs, resulting in increase of their smooth muscle, thrombosis within the vessels, and just overall thickening. And this results in a pulmonary increase in their pulmonary vascular resistance, which eventually causes their RV pressures to go up, and eventually they actually start to shunt reversed through their VSD or ASD or whatever it may be. They'll go right to left, and that results in cyanosis. As a reminder, they kind of have a number of different findings. They can be very polycythemic. They can be coagulopathic. Gout is very common just due to high red blood cell turnover, renal dysfunction related to a lot of the coagulopathy, strokes related to the coagulopathy and the shunt itself. They have a high risk of atrial fibrillation, and then pregnancy has been shown to be very high risk in these patients with up to 50% risk of mortality. So this is in that class 4. We obviously stay away. We try to strongly recommend against pregnancy in our Eisenmenger patients. In one study looking at maternal oxygen saturations, if it's less than 85%, the live birth rate is 12%. So clearly, if you are quite desaturated, you're just not able to provide enough oxygenated blood flow to the fetus, and they just don't survive in that condition. We do not do phlebotomy on these patients. It used to be very commonplace to do, but that's been found to be associated with increased risk. Some may benefit from supplemental oxygen during a pregnancy to just try to help improve the saturations. When they come in for delivery, or if they're seen in triage, they should all have air filters to prevent paradoxical emboli from crossing and going to the brain. There are no cardiac indications for C-section in them, and then they usually should be monitored for 48 hours in the ICU. Fortunately, we don't see very much Eisenmenger pregnancy anymore. I think the majority of those that we see now are largely coming in from countries where healthcare was somewhat unavailable. The last patient I can remember was a young woman who had a large ASD who presented over at Midtown. She's doing well now. Baby's doing well. She's on pH therapy. We were able to get her through, but certainly was a lot of stress for the entire team. We'll end with a discussion on single ventricles. These are my favorites. So single ventricles can really be divided into a number of different categories, either with a small left heart, small right heart, or they can have kind of complex forms. But ultimately, they all have either systemic or pulmonary outflow tract obstruction. These are just a few different types. This top one is a patient with hypoplastic left heart syndrome with a very small LV. This is a patient with tricuspid atresia with a very small RV. And then this is a patient with unbalanced AV canal, where basically all the inflow went to the left ventricle, so the RV stayed very small. We do a series of surgeries to palliate these patients early on in life. We usually do something called a Norwood operation with a Blalock-Taussig-Thomas shunt to create a source of pulmonary blood flow. Ultimately, though, they outgrow this operation, and we will do something called a Glenn, where we attach the SVC to the branch pulmonary arteries directly, and then eventually they need something called a Fontan that attaches the IVC. Fontan physiology is very complex. It's very reliant on just getting this video to play, hopefully. I don't know why it won't, but it's very reliant on the patient having low systemic filling pressure and thoracic pressure to promote flow from the IVC and SVC through the pulmonary vascular bed. So these patients don't tolerate elevated pressures in the chest very well. They don't tolerate elevated pressures within their ventricle very well. So this is one of our patients who had pretty reduced LV function. And then this is something called 40 flow MRI, just basically showing flow of the blood through that Fontan and through the pulmonary arteries. A lot of them develop progressive cardiac dysfunction, usually by the time they're in their teens or 20s, so they have a difficulty augmenting their cardiac output. Many will have arrhythmia issues. Cyanosis is very common, and a lot will develop sick sinus syndrome, so they can't augment their heart rate either. So they have multiple different reasons for not tolerating a pregnancy well, and then finally they also can have significant liver dysfunction. Fontans have a lot of problems in pregnancy. They have trouble augmenting their cardiac output. Those with a RV, a single RV, are going to be much more at risk than LVs. These patients are now surviving more and more into adulthood. They historically have not, so we're going to see more and more of them. They have a very high arrhythmia risk. They have increased thromboembolism risk, and they can develop IVC obstruction from the baby. That can result in poor flow through that IVC to the heart, decreased filling, and a reduction in their cardiac output. So anything that increases pressures in the chest, intubation, positive pressure ventilation, being quite pregnant can do it. If they develop a pulmonary embolism, anything like that drastically tank their cardiac output very quickly. So when we're talking about pregnancy in Fontan patients, we do a baseline evaluation, including cardiopulmonary exercise testing, and everybody, liver assessment is good. There's some literature that has suggested that all patients should be put on Lovenox or low molecular weight heparin. There's not strong evidence to suggest that should be done in everybody. I think we have been generally pretty aggressive about this. Those who are already on aspirin should definitely stay on aspirin if possible. They are at much higher risk of thromboembolism. As we talked about, IV obstruction late in pregnancy may cause decompensation just due to poor flow back to the heart and a decrease in the cardiac output that already can be kind of low. Fontan delivery, so when they come in for delivery, we really should avoid general anesthesia for these patients as often as possible. If they have positive pressure ventilation, it can reduce cardiac output. Fluid balance has to be maintained, so they need some preload, so they have to be hydrated enough to maintain their Fontan and Glen pressure to kind of push things through the lungs. But if they get too much fluid, they can actually exacerbate CHF and they can tank that way. So they have to be just right with that. I think anyone who has reduced function should probably be considered for C-section if they have a Fontan. And then assisted second stage is probably a great idea. They generally don't tolerate long labor. Telemetry for all of them is needed. And then they should probably be monitored in the ICU for at least 24 to 48 hours after delivery. Looking at just pregnancy outcomes, this is a relatively recent paper from 2018. This is maternal CV complications in Fontans. This was in a group of 135 patients. You can see that supraventricular arrhythmia was the most common complication. Heart failure happened in about 4%. I feel like this has to be low. This seems much lower than our experience. It'd be interesting to kind of pull our data, but this does seem a little on the low end. Obstetric complications are a little bit higher here. So of those 255 pregnancies in this paper, 137 of them experienced loss. 115 of those were spontaneous and 19 were elective. There was 115 live births, but you can see just how high the prematurity rate was. It's almost 60%. And then there were a few neonatal deaths as well. So these patients are at very high risk of complications during and after pregnancy. So let's talk about our case that we started with. So she was initially, just as a reminder, presented at 10 weeks, G1P0, presented at her pediatric cardiologist office. He's a good friend of mine, so was able to call me and say, I need her seen as soon as possible. She came in 2 weeks later and saw us and our MFM team all on the same day. Echo here shows that her function was okay, but probably kind of in the low normal range for both her LV and RV. Again, we looked at her pulmonary valve. She has some mild stenosis, but probably moderate regurgitation as well. She developed some increased palpitations through the mid portion of the pregnancy and had a Holter monitor placed, which showed PVCs, and then but didn't require treatment for that. But then when she came back in the early third trimester, she saw MFM first, had a blood pressure of 146/94 and some lower extremity edema. Came over to our clinic right after that. Blood pressure was still elevated, had pretty elevated JVD, and urinalysis then showed protein. So she was suspected to have preeclampsia and decompensated right heart failure. We admitted her from clinic and started her on blood pressure control and diuresis for a few days and met as a team and ended up deciding that she should have an induced delivery at about 31 and 2. Fortunately, her hemodynamics improved significantly, and baby was in the NICU for a while, but I think is doing well now. Mom's is doing well and is currently being kind of evaluated for valve-in-valve pulmonary valve replacement due to the degree of dysfunction that she experienced. So take-home points from today. I think this is review. Pregnancy is a high flow, low resistant circulation, which can impact the cardiac system in many ways. Preconception counseling is an absolutely critical part of management of a woman with congenital heart disease. There's nothing worse than an unplanned pregnancy in these patients. Management of pregnancy in the CHD patients is extremely complex, dependent on a number of different factors, including the original diagnosis, surgical procedures, presence of residual disease, or other complicating factors. And I think just lends itself to knowing that we need that really good team-based effort between OB, MFM, ACHD, the anesthesia, heart failure, surgery, in order to have optimal outcomes. And this is our team, and that's my contact information. Please don't hesitate to email me or call me if you have any questions or anything. Dr. Book, Dr. Jokadar, Dr. Rodriguez, Dr. Harden just joined us, and then myself. And then I think we've got a few minutes for any questions or comments, and we can kind of go from there.
Wow, thank you so much, Dr. Smith. That was a fantastic presentation. I was fascinated the entire time. So thank you for that. And if anybody has any questions right now, you can feel free to put those in the chat or come off your line, unmute yourself. And I think as folks are getting brave enough, I mean, I would ask to the group that's joining here, you know, the experience you all have had with pregnant women coming in with existing cardiac conditions. And, you know, you talk, I think, Dr. Smith, you mentioned, you know, not having an established cardiologist and just kind of seeing general practitioner right now. And so what are some of the other challenges folks on the call have been experiencing with these patients?
I was laughing when Dr. Smith said he loved Fontans, and I was like, oh, you better you than me, my friend. I think one of the challenges I've had, and I train near CHOP, so I saw a lot of congenital cardiac patients when I was a fellow, is that a lot of our patients would do fine during delivery. They would do okay in the immediate postpartum period and then decompensate somewhere between 3 to 6 months postpartum. And I think one of the struggles from the OB team is that we may not know that they were admitted because they often go straight to cardiology. And so it was hard for us to know, to get a real accurate sense of what our patients did during pregnancy, because a lot of their complications came long after the delivery. I don't know if you can speak to that. I know when you have a congenital cardiac, you know, program, they get followed appropriately,
Yeah.
but it's a lot harder when they don't have it, you don't have that resource.
You know, I talked a little bit about that transition from you know, teenage years to young adulthood that is a struggle for us. But I think that transition just from, you know, the time that they were pregnant to the time that they're no longer pregnant is also a huge struggle. You know, we lose a lot of patients that way. You know, they just disappear on us, and you know, they'll be at Midtown, they'll have their baby, and then we don't see them again until, you know, X number of months or years later. I have one that's supposed to be seeing me later this week. I haven't seen her since. She's a severe mitral stenosis who hasn't seen me since her delivery in, I think, October. So, you know, I think it just tells us again that we have to be better about this transition process. You know, I think I don't know where the gaps are. I think there's a lot of them. I think there's access to care issues. There's, you know, education issues. It's just insurance issues. It's also challenging, but I think it's one of the biggest problems we face.
Hey, it's Jane Ellis. I'm one of Dr. Duty's partners here at Grady. Thank you for that excellent talk. I'm just curious for your, and I work with a number of the Sibley cardiologists who come to Grady for fetal echoes. Just curious, and I know what they've told me, for if you have patients, say, that are young girls, 10, 11, 12-year-old patients, who you suspect that pregnancy will not be good for these patients down the road, do y'all start counseling them early on pregnancy avoidance? Do you talk to their pediatricians about counseling? How do you handle that?
It's a great question. I think it largely depends on the cardiologist. I do think it really does. I think, especially in the pediatric world, some of us are more comfortable with these conversations than others. And in talking to a lot of my partners on the children's side, it's inconsistent. You know, if I was to give you a number, I bet it's less than 50% that are doing routine counseling about pregnancy, and that's an important part of the transition process. You know, it should be one of those conversations that's happening starting in the, you know, 12, 13 years old range and progressing until they move to adult care. So I've given a similar talk to this one a couple of times to my partners on the children's side, and I really hit that preconception side really hard, because I think they have to understand that that's probably one of our biggest and best ways to kind of impact the care of these patients going forward.
Especially since there's been a change in the Georgia law recently on the ability to terminate if a patient is pregnant, and that's not, you know, the best thing for her. So thank you for that information. I appreciate it.
Yeah, absolutely. Thank you.
All right, we got 1 minute left. So if anybody has any glaring questions, I see Dr. Kaki put something in the chat. Are there community organizations that support families of youth with CHD?
There are, and I'm happy to kind of send some of those over if that would be helpful to you. There's a lot of different ones. A lot of them are through CHOA. There's a couple kind of private groups that have kind of come up. One of my that help. One of my favorite organizations is the Adult Congenital Heart Association. It's the achaheart.org. Is their website. They are very well organized, both here in Georgia and nationally. Lots of nice resources, some peer mentoring program through that. That's amazing. One of my patients is a mentor through that, and she just recently had a baby, so I've had a couple of my other patients meet with her about, what was it like getting through pregnancy with a history of CHD. So I'm happy to provide some more of those names of those resources if that would be something you all would like. But no, there's definitely some nice ones out there.
That would be greatly appreciated. You can send them my way and I can disseminate to the group. We are at 3 o'clock, so we've used the entire time. Dr. Smith, that was fantastic. We appreciate you spending time with our group and as we are kicking off our new initiative, and would appreciate the connection going forward as we all partner collaboratively in this great effort. So appreciate you all for joining today. And this will be on our website, our recording and the presentation. So thanks again, and everyone have a great rest of your day.
Thank you so much. Thanks for having me.
Thank you.